very happy to have our dear Suman sir as a faculty for this session. And on this occasion, I would like to welcome our President of Kerala IAP, Jose sir, to this platform. And we have along with us, we have the Shanavas sir, who is the state coordinator for the PG Clinical Club. And we have our senior faculty members, Purushothaman sir, Cyril sir, who is a mentor for this topic, today's session. And also we have Darli madam with us. I welcome all of you to this program. Now I request Dr. Jose sir to have the introduction remarks.
Thank you. Am I audible?
Yes, yes sir. Yes, sir.
Good evening. Thank you, Dr. Suresh, and thank you, IAP Kottayam, respected Sumar sir, and HOD of ICH, Dr. Darli madam. Today, the mentor, Dr. Professor Cyril, and the presenter, Dr. Anshad, and the coordinating this program, Dr. Suresh, and all the senior faculties of the program, Dr. Purushottam sir, our state convener of this program, Dr. Shanavas sir, and along with our dynamic secretary, Dr. Krishna Mohan is here, and all the faculties and all the PG students, and good evening to all. And this is the 29th weekday program for Clinical Club conducting when the action plan Synergy 2023 is concerned, and we are regularly conducting the program every Thursday, and it was very much appreciated by the PG students, by the expert faculty. They have an opportunity to discuss with the expert faculty today from the all over the Kerala. I think this is a very useful program for the PG students concerned. There, how to approach a case and how to be what are the diagnostic dilemma in common issues and various aspects with different program, different clinical case. We are going already finished the discussions, and all the PG clinical programs are we are uploaded in our website and designed by Dr. Praveen K.S. And it's a beautifully designed our IAP Kerala website. I request all the PGs and all the IAPNs and all the members to visit our website and to utilize this PG clinical program for review for their clinical update is concerned. Again, I request this next week is our ORS week celebration going to celebrate, and I request all the PG students and all the IAP members to celebrate our ORS week celebration in a fantastic manner. The state level inauguration going to be inaugurated on next Tuesday at Cosmopolitan Hospital, Trivandrum, and we are going to request all the branch office bearers to conduct the program in an excellent manner and report to the state secretary regarding the activities concerned. And today, another important clinical case discussion, none other than teacher of teacher, my guru and all of the guru, Dr. Sumar sir is here to discuss one of the respiratory issues in common day-to-day for the PGs is concerned. I think today program will be enlightening all of us regarding the common issues or respiratory asthma and related issues. I think it will be very useful program. I wish you all the best. Jai Hind, Jai AP. Suresh, you unmute and
Thank you, Jose sir, for your kind words and introduction. Now I request Shanavas sir to say a few words.
So very good evening to all. Respected IAP State President Jose sir, today's Chief Guest Dr. Sumaran sir, and all the member IAP of Kottayam, and Dr. Darli madam and Dr. Cyril sir for conducting today's case. And every time when the turn of Kottayam comes, they are very much interested and very enthusiastically taking cases and presenting. And today also they are doing it very wonderfully. I think one of the common problem, and most of the time could be as an ambulatory case, or in the case of DNB students as a case of short case, and we had also a common practical problem also. Today's discussion will be very useful, and I express all the best for the program. Thank you.
Over to Darli madam. Thank you, sir. Over to Darli madam.
State President Dr. Jose, respected Suman sir, Purushothaman sir, Shanavas sir, and all the dignitaries in the platform. I'm really happy to be in this platform with Suman sir, because once again sitting with him for a class, that is really all those things learned from sir that is regarding visas. Especially all visas are not asthma, those things that we always remember when we see cases actually. So for our students also, it's always a nice thing to hear from Suman sir. And I wish this program all success also. Thank you.
Thank you, madam. Thank you. Thank you, madam. Over to Cyril sir. Cyril sir being the mentor for ANSHAS for this case. And the case is from P2 unit of our department. Cyril sir.
Respected Sumaran sir, Purushottam sir, and other teachers, colleagues, and PGs. I'm very happy to be associated with this program, mainly because after 25 years, I think I'm able to attend a class by Sumaran sir. I'm waiting eagerly to hear from sir. As Matt has rightly said, all the visas are not asthma, and also sir used to tell about the A, B, C, D, F, G, which I still remember that. Very happy to see sir. I'm waiting to hear from sir. I wish all the best for this program.
Thank you, Cyril sir. Thank you, Cyril sir. It's time to start our session right now, and I wish all the best for Anshad, who is our resident, junior resident in the pediatrics department of ICU.
I think Dr. Krishna Mohan is there. Krishna Mohan is there.
No problem, sir. I proceed because I am driving now. Please proceed, sir. Please proceed.
Okay, thank you, Krishna Mohan. Thank you, Krishna Mohan. There is no need to introduce Suman sir because he is the teacher of teachers and he is the last word in case of asthma, especially in state of Kerala is concerned, at least. So over to you, Suman sir, for the discussion part.
Okay. Good evening, everybody. Beloved State President Dr. Jose, Secretary Krishna Mohan, Treasurer Ranjit, and the faculty from ICH Kottayam, HOD Dr. Darli, Dr. Suresh, then Dr. Cyril, who has joined us, professor in ICH Kottayam, Dr. Suresh, the coordinator, and senior professors, Dr. Purushottam, and my beloved friends and students. It gives me great pleasure and privilege to be here with you again to take a class on common respiratory problems in children. I left ICH Kottayam 17 years back, I think that's 16 years back. And I was in Pushpagiri and I left Pushpagiri also 4 years back. So, so I had not taken a class except for the class in association with PG last year. Otherwise, for the last 4 years, I am not taking a PG class also. And so this class will be a revision for me also. And today is another memorable day for all of us because the funeral function of our late Chief Minister, Mr. Ummanchandi sir, is taking place in Pudupulli the same time. So I asked Jose whether we have to postpone it or not. Jose said we will proceed with the academic program. So I'm very, very happy to be here. Then again, regarding the presenter phoned me up and told me that her name is Anshad. I thought Anshad is a male name because we had a PG, the same name, Anshad, in Pushpagiri. Now, later he told me that she is Anshad's Begum. Then very happy to be here with, happy to introduce Dr. Anshad Begum. And I request Dr. Anshad Begum to start her presentation. Before the presentation, I want to say that for every clinical problem, you can make a diagnosis. You present a clinical problem to make a diagnosis and manage. For every case, you can have a diagnosis at 3 levels. The first diagnosis comes after history. So I must present a very detailed history and make a diagnosis after history. The second diagnosis comes after investigations. Then the final diagnosis comes after investigation. Second diagnosis comes after physical examination. First diagnosis after history, second diagnosis after physical examination, and final diagnosis after investigations. So with these words, I request Dr. Anshad Begum to present the case. And I'll be asking questions in between to Anshad and other PGs. I think we can start now.
Yes, sir. Thank you.
And also very happy that ICH, we can see our own photos, retired faculty photos are there, kept there.
Sir, can I start?
Yeah.
Yeah, okay. Good afternoon, everybody. Presenting the case of a 6-year-old girl child hailing from Alappuzha who got admitted to our department P2 unit on 11th of July 2023, and examination was done on 15th of July 2023. The informant was mother and history appears reliable. Child presented with recurrent episodes of cough, noisy breathing and breathlessness since 1.5 years of age. And the first episode.
Just wait, Anshat. I think we can start our clinical discussion even from the presenting symptom. This child has presented with mainly 3 symptoms: recurrent episodes of cough, noisy breathing, and breathlessness. So what do you think? Which system is affected in this child?
Respiratory system.
Why you said this respiratory system? Why couldn't it be a cardiovascular system? Yes, you say points 1, 2, 3. That is enough.
There is recurrence of symptoms since 1.5 years of age with the fairly normal period in between. And the child has a response to.
No. From the symptom, there are, you said only 3 symptoms. Recurrent episodes of cough, noisy breathing, and breathlessness. With these symptoms, what do you think? Respiratory or cardiac?
Probably respiratory.
Why so?
Cough and noisy breathing is more seen in respiratory cases. Breathlessness can be seen in cardiac also, but it is usually during exertion.
Okay. It can be either a respiratory problem or a cardiac problem, but most of the symptoms are connected to the respiratory problem because recurrent episodes of cough. What do you mean recurrent episodes of cough? What do you mean
child gets cough at around 2 to 3.
What do you mean by recurrent cough?
Every 2-3 weeks.
Yeah.
Very frequent, once or twice, 2 episodes, 3 episodes a month.
What is recurrent cough means the child will have cough for 1 week. Then we give some drugs, cough stops. Again, after 1 week, the child will present with cough. That is called a recurrent cough, which is usually seen in children with asthma. What do you mean chronic cough? What is the definition of chronic cough?
More than 2 weeks.
More than 2 weeks. Or 3
lasting
weeks.
more than 2 weeks without symptom-free period in between.
That is symptom-free. Usually, in a child with a chronic cough, they will present with a persistent cough, which lasts for 3 to 4 weeks. Some say it is 3 weeks, some say it is 4 weeks, but latest guidance say that it's again after 2 weeks is called as a chronic cough. So this child is present with episodes of cough and noisy breathing. That's the most important symptom in this child. What are the causes of noisy breathing in a child? What are the respiratory problems that present with noisy breathing?
Noisy breathing, it could be wheezing as in case of asthma, or any upper airway obstruction leading to a stridor as in case of croup, or any foreign body obstruction. Or it can be snoring as in case of nasopharyngeal obstruction in case of adenotonsillar hypertrophy. Grunt as in case of parenchymal issue like pneumonia.
Usually, I say you can have 6 noisy breathing in children with respiratory problem. One is called snuffle. Snuffle means a child with a nasal obstruction. They can present with snuffle, or sniffling can be there. Second is an upper airway obstruction. As you said, if the child is present with snoring, the problem is in the nasopharynx. The commonest condition will be and child present with adenoid hypertrophy. Then stridor. Stridor can be due to a problem in the larynx or trachea. It can be a supraglottic problem, glottic or infraglottic problem. So it can present with stridor. And the third sound I want to say is wheezing. Wheezing occurs as a problem in the bronchus and bronchioles. Then there is another called rattling. Rattling is the sound produced due to retained secretions in the bronchus. For example, in a child with a bronchiectasis, they can present with rattling. Then last one and most important is grunting. Grunting means the child is having a lung parenchymal disease. So by taking a very detailed history, you must try to find out what is the type of noisy breathing. And from the type of noisy breathing, you can localize the disease. Just like a neurological problem, you can localize which part of the respiratory system is affected and what will be the probable etiological factor. So it can be either respiratory or cardiac. Because of the cough, persistent cough, noisy breathing, and breathlessness may be a respiratory problem. Proceed, please proceed. Proceed. Anshat, proceed. Next slide.
Moving to the next slide, first episode of breathlessness following an upper respiratory tract infection occurred at 1.5 years of age, for which the child was admitted for 3 days in a local hospital and was treated with multiple nebulizations and IV medications. And second episode of admission occurred at 2 years.
What is the response for nebulization?
Child improved, sir. Child improved with the multiple nebulizations and medications and was admitted for 3 days only.
Okay.
Second episode of admission at 2 years in local hospital and was admitted for 5 days. And child was having recurrent episodes of breathlessness since then, with a frequency of at least once in every 2 to 3 months.
Proceed.
Requires emergency room visits and overnight emergency room stay. Usually episodes are triggered by dust, cold, or upper respiratory tract infection. And third episode of admission occurred at 6 years of age in January 2023. Got admitted in our institute and was admitted in ward for 4 days. Was managed again with the nebulizations and IV medication followed by oral drugs. Child used to have cough about once in every month that gets relieved with the salbutamol syrup since about 1 year of age, according to mother. For last 1 year, child is having symptoms about 2 to 3 times every month, missing school about 4 to 5 days every month. Nocturnal symptoms and awakening about once in every 2 to 3 months initially, and for past 1 year about once per
And
month.
you can say something more about the cough. What is the timing of the cough in this child? Timing of the cough is very, very important.
Cough worsens by around
Around
hours after about 2 a.m. And
around 2 a.m.
cough is usually dry to begin with and sometimes later becomes productive.
It's very nocturnal.
Nocturnal.
What are the common conditions that produce a nocturnal cough?
Post asthma.
Yeah.
And postnasal drip.
Yeah. Then
GERD.
Predominantly nocturnal. Then
Sir.
yes. What are other conditions? See, timing of the cough is very, very, very important. See, you said about postnasal drip. Postnasal drip. In postnasal drip, the child present with cough immediately after going to bed.
Immediately.
For example, the child goes to bed and within half an hour, the child wakes up with cough, most probably, and it may be a postnasal drip. Second is GERD. GERD also present with cough, wheezing, and also vomiting some 1 to 2 hours after going to bed. And a child with a cardiac problem, especially paroxysmal nocturnal dyspnea also, they can present with cough around 1 hour after going to bed. This timing is it's a relatively good timing. Then you said in a child with asthma, the cough is mainly present around 2 a.m., 3 a.m., 4 a.m. If a child is is waking up with a persistent cough around 2 a.m., 3 a.m., 4 a.m., and he respond to a nebulized salbutamol, most probable diagnosis is asthma. So asthma will present with nocturnal cough. Persistent cough in the early morning hours is suggestive of asthma. If that history is not there, most probably it is not asthma in a child. Then in children with bronchiectasis also they can present with the early morning cough with expectation of purulent sputum. Suppose a child is presenting with persistent cough during daytime, and when the child sleeps, the cough subsides. What is the diagnosis? That's a very common scenario that we see.
Foreign body. Foreign body.
Foreign bodies will have persistent cough during day and night. There will be no difference. So cough will be there during daytime, but night they'll be sleeping. Yes, it's called a psychogenic cough or a habit cough. That is very common in a child, especially after school opening now. We are seeing a lot of children with psychogenic cough or a habit cough. They will present with a persistent cough during the time. Even mothers say when the child sleeps, there will be no cough. That is very, very important. So that is why the timing of the cough is very, very important. In this child, you said, is around early morning hours. It's not so. And child responds to oral salbutamol and nebulized salbutamol. Yes, negative points, sir.
Yes, noise foreign body aspiration, noise surgery in newborn period, noise recurrent regurgitation of feed or vomiting, noise failure to thrive, palpitation or dyspnea.
Why you asked about surgery in the newborn period? Surgery in the newborn period.
Any tracheoesophageal fistula.
But can be tracheostomy. See, this child has presented with first episode of wheezing was at 1.5 years. No, yes. First episode. If a child is presenting with first episode of wheezing at 1.5 years, the congenital malformation are unlikely. But if a child is presented with wheezing, cough from early infancy, you must think of congenital malformation, like tracheoesophageal fistula. But it is seen that those children who had undergone tracheoesophageal fistula repair, they can later present with cough because of the esophageal stenosis, and also there's a high incidence of GERD after tracheoesophageal fistula correction. Okay, right?
Noise of recurrent regurgitation of feed or vomiting, noise of failure to thrive, palpitation or dyspnea on exertion, noise of chronic diarrhea.
What is the importance of all these things? Failure to thrive, chronic diarrhea.
Failure to thrive, palpitation and dyspnea on exertion to rule out any cardiac causes.
Yeah.
And failure to thrive and chronic diarrhea and cystic fibrosis also. Then,
Now also we are seeing children with cystic fibrosis. They can present with recurrent episodes of cough, wheezing, later bronchiectasis, chronic diarrhea, malabsorption, pancreatitis, etc. All this history is important, right?
recurrent regurgitation of feed and vomiting to rule out GERD.
Right.
Now, child was started on Budicort MDI since last admission and was stopped after 3 months. History of sneezing.
What is the dose of Budicort that is given?
100 microgram, 1 puff PD was given.
1 puff PD.
Low dose only. History of sneezing episodes with nasal discharge during every morning since last 1 year, for which child is on mometasone nasal spray for past 3 months. No history of nasal block or nasal itching, no history of eye itch.
So what is this history suggestive of?
Allergic rhinitis.
What is the criteria for diagnosis of allergic rhinitis?
ARIA guidelines.
What is ARIA guidelines? What is the full form of ARIA? ARIA.
Allergic rhinitis impact on asthma.
ARIA means allergic rhinitis and its impact on asthma. There is an ARIA classification is there, and just like asthma, there's a step-up management of allergic rhinitis is there. It's called ARIA guidelines. What are the symptoms in ARIA guidelines for diagnosis of allergic rhinitis? What are the 4 symptoms?
Nasal discharge, sneezing.
Watery nasal discharge.
Nasal block and nasal itching.
Among these 4 symptoms, how many symptoms should be there? All symptoms?
At least 2 for 2 weeks.
At least among these 4 symptoms, 2 symptoms should be there for a period of at least 1 hour per day for a long period. Long period is taken as 2 weeks. Then is allergic rhinitis. In all children with wheezing, we must ask the history of allergic. Is it allergic rhinitis? He has presented with sneezing episode and with nasal discharge every morning for the last 1 year. And the child is on mometasone nasal spray. What is the response to mometasone nasal spray?
Very good, sir. Child is comparatively symptom-free for past 3 months.
Because if the child is having allergic rhinitis, you must look for a response. They will respond to mometasone. Okay.
Now the
what is
present
episode, itching of the eyes? Itching of the eyes, you said?
Associated
allergic conjunctivitis.
Allergic conjunctivitis.
See, all these allergies, mainly we see 4 or 5 allergies in children. First one is atopic dermatitis, which manifests in the first month of life. Atopic dermatitis. Then these children develop asthma. Then they develop allergic rhinitis. And later, in the early phase, they can have food allergy also and urticaria also. This is what is called an allergic march. Atopic dermatitis followed by asthma, allergic rhinitis, and food allergy. This is called atopic march. All these 4 allergies occurs in a child. Okay, right.
In the present episode, child presented with a cough 1 day, noisy breathing for 1 day, and breathlessness for 1 day. And it started as rhinitis with watery nasal discharge and sneezing, which got worsened by night. And next day, child had dry cough that became productive with white mucoid sputum. After a few bouts of cough, mother noticed noisy breathing with associated breathlessness in the form of fast breathing and increased work of breathing. Breathlessness got worsened overnight, and child was not able to speak in words by early morning 4 a.m. At that time, mother took the child to nearby hospital.
Why you asked about difficulty in speaking?
Sir?
Why you asked the history of difficulty in speaking? You said the child had difficulty in speaking.
To assess the severity of asthma.
To assess the severity of acute episode. Acute
exacerbation. And then no history of cyanosis, convulsion, altered sensorium of stridor, no history of fever, no
What
history
is
of
the
rash
importance of
or
all these things? Cyanosis, convulsion, altered sensorium, stride up.
Sir,
What is the importance of all these things? Why you ask about history of cyanosis, convulsion?
the danger signs, no history of cyanosis, convulsions, altered sensorium, stridor in a calm child, all of this considered to be.
But these are the danger signs of pneumonia, not asthma, no?
um,
Danger signs of pneumonia and not asthma. Okay.
Fever to look for an associated infection.
Infection where?
Upper respiratory tract.
Is strep fever a common presentation of asthma?
No,
Or
no,
is it febrile?
no, sir.
But see, when you discuss the symptomatology of asthma and also for management of asthma and all guidelines, they say that you can discuss in 3 age groups. First is children less than 5 years, 6 to 11 years, 12 years and above, adults and adolescents. But in children less than 5 years, it's called an under 5 visa. Under 5 visa, they can present with fever. What are the types of under 5 visa? Any idea?
Episodic visas and multi-trigger visas.
And the old classification is called an episodic viral vis and multi-trigger vis. What is episodic viral vis?
They will be usually symptomatic during the time of an upper respiratory tract infection, with comparatively symptom-free in between.
And also the fever. There will be a febrile onset. See, all these children with episodic viral vis, the first symptom they will present with an acute upper respiratory infection with fever. The febrile onset is there. And in between, they are asymptomatic. And what happens to children with episodic viral vis, natural history? They will persist or disappear. Symptom.
Whether the episode occurred during an upper respiratory tract infection.
No, it is most probably it is precipitated by viral infection. Which are the viruses that precipitate an episodic viral vis?
Respiratory syncytial virus.
But respiratory syncytial virus is not the commonest virus that precipitate an episodic viral vis. What is the condition produced by RSV virus?
Bronchiolitis.
Bronchiolitis. But even RSV can also precipitate asthma with episodic viral vis. But that is not the commonest organism.
Rhinovirus. Influenza, metapneumovirus.
Broca virus, adenovirus, etc. So the fever may be there only in children less than 5 years. Children less than 5 years, fever may be there. But all the children usually they will present without fever. And also in the second group, in children with a multi-trigger vis, usually they present without fever. What is multi-trigger vis? What are the features of multi-trigger vis?
Child will be symptomatic in between in between upper respiratory tract infections. Also, child will be symptomatic. They will be triggered by other agents like pollutants, aeroallergens, etc. Exercise.
Yes. Then the other thing is that in a child, the most important feature is there's a family history of atopy, family history of asthma, allergic rhinitis, or atopic dermatitis in a child. In a child with multi-trigger vis. And also a personal history may be there. Along with wheezing, the child may have atopic dermatitis or allergic rhinitis. If such a family history is there, the history of atopy is there, and it's triggered by other factors like exposure to cold or to passive tobacco smoke, that may be a multi-trigger vis. And children with multi-trigger vis, they continue as asthmatic later in life. These are the two conditions that can present with wheezing in children less than 5 years. Okay, and children less than 5 years, they can present with fever. But older children, usually fever will not be there unless they develop some complications. Okay, right.
Child was initially taken to, during the present episode, initially taken to a local hospital at early morning and was treated with nebulizations and IV medications, had desaturation and hence was referred here. Child was symptomatically better after initial nebulizations, but the breathlessness was persisting. Hence was referred.
Okay.
Then admitted in our high dependency unit as child had a PSI score of 7 at admission and hypoxia. SpO2 was 88% in room air. Was treated
Just
with
can you highlight
nebulization.
what is PSI? those listeners who may not.
PSI score
No.
is used to assess the severity of asthma in acute exacerbations.
Yeah.
It includes first the respiratory rate, which is divided into two categories: less than 6-year-old and more than 6-year-old. In less than 6-year-old, it is taken as 0 if it is less than 30, and in more than 6-year-old, it is less than 20. Then 20 to 35 taken as 1, and 30 to 45 taken as 1 in case more than 6-year-old. Then 45 to 60 and 35 to 50, and more than 50 in case of more than 6-year-old.
Can you show? I think there's a slide there in your
Yes,
presentation.
sir.
Can you just show that slide?
Okay, sir.
This is the PSI. PSI is very, very, very important for assessing the severity. We go for 3 criteria: respiratory rate, accessory muscles, and wheezing. And grading is if the score is 3, mild. Moderate is score is 4 to
5,
6,
6
and
moderate.
more than 6
More
is
than
severe.
6 is
All
severe.
children above 6 should be admitted in a PICU. But you know what is the problem in this criteria? This is a very simple criteria, but some problems are there. See, the most important criteria that is lacking here is the sensorium of the child. Sensorium is very, very important. So you must look at the sensorium. The child is drowsy or the child is going for respiratory failure. So I think the only problem in this classification, this grading is absence of saturation, absence of sensorium. Sensorium is not given an importance here. Okay, please proceed. This is what is called PSI. Okay, proceed.
Was treated with nebulizations 20 minutes apart 3 times, followed by hourly nebulization and IV steroid was given. Oxygen support was given via mask. And as PSI remind 5 was given magnesium sulfate. Nebulization was gradually changed to MDA and was spaced out. Oxygen was weaned off the room around 3rd day.
Magnesium sulfate, how magnesium sulfate is given? How?
Sir?
How magnesium sulfate is given? IV nebulized?
0.5 ml per kg at a period of
How it is given?
30 minutes.
What is the dose? Dose of
50,
magnesium sulfate? That's right.
0.5 ml per kg of 50% of magnesium sulfate.
What is the mechanism of action of magnesium sulfate?
Smooth
Mechanism, how it
muscle,
acts?
sir.
What is the mechanism of
Smooth
action
muscle
of?
relaxation.
Yeah, how?
In the bronchus, there are
bronchus?
the bronchoconstriction is mainly mediated by the smooth muscles in the bronchioles,
Yeah.
which is being the bronchoconstriction
Bronchoconstriction is relieved.
is
How?
one of the main
How?
cause for the airway obstruction in asthma.
Right, that
So,
is right. So how it acts?
When the environmental factors,
No, magnesium sulfate. How magnesium sulfate produce a relaxation of the bronchus, bronchial smooth muscle. Magnesium sulfate will prevent the influx of calcium in the smooth muscle. So there will be smooth muscle relaxation. Second point, it will inhibit the release of histamine. So it has got an antihistaminic effect. And third one is it will inhibit the release of acetylcholine. So it has got an bronchodilator effect, antihistamine effect, and inflammatory effect is also there. And anticholinergic effect is there for magnesium sulfate. Then is it given in is magnesium sulfate given as nebulization now?
it can be given.
How it is given? And what is the indication? I think you must have read the new GINA guidelines. Even 3 years back, the GINA has said you can try nebulized magnesium sulfate.
In older children,
Older children means how much older?
more than 6-year-old.
No, more than 2 years. In GINA say they can give magnesium sulfate in children, nebulized magnesium sulfate in children about 2 years. And what is the dose? Dose of nebulized magnesium sulfate should be 150 milligrams. 150 milligram. No, 150 milligram. 150 milligram to be diluted in 3 ml of normal saline. And you can give in the first 1 hour of acute asthma. First 1 hour. Early, you can just give nebulized magnesium sulfate. 150 milligram to be diluted in 3 ml of normal saline. You can repeat 3 doses. It can be given. So this child is given IV magnesium sulfate.
IV magnesium. First, now antenatal
Yeah.
first child of non-consanguineous marriage, child antenatally uneventful, underwent full-term cesarean section with a birth weight of 3.1 kg. Child cried soon after birth. No history of any NICU admissions.
What is about cesarean section and wheezing child? Wheezing. Is there a correlation between
Some
cesarean
studies
section and
have
wheezing?
shown increased incidence of
Oh.
asthma in children with the cesarean section.
Children born by cesarean section. What is about the gestational age and wheezing episode?
Preterm children also has got high risk for some studies have shown increased incidence in preterm infants also.
So always you must promote an vaginal delivery because there's a high incidence of asthma in children born by cesarean section, right?
All milestones were, moving on to the developmental history, all milestones were attained at appropriate age without any developmental delay. Now the child studies in second standard with a good scholastic performance. And nutritional history, child is getting a diet deficient of 236 kilocalorie with a 3 gram protein excess, lacks good quality protein and green leafy vegetable. Child was
What is
immunized
the importance
for
of green leafy vegetables? Will you order green leafy vegetables for our children with asthma, wheezing? Fruits,
micronutrient
green leafy
deficiency.
vegetables, yes, right?
Micronutrient deficiency, like a zinc deficiency,
Oh.
has shown to have chronic
Zinc deficiency will
effect
not
on-
be chronic respiratory problem. See, the way it is seen that children should be given dietary items which contains more antioxidants. Antioxidants are there in fruits and vegetables. So you must advise these children to take more green leafy vegetables and fruits, which contains more antioxidants. Okay. Right.
Immunized for age according to the National Immunization Program, but pneumococcal conjugate vaccine or influenza vaccine was not taken.
What can pneumococcal conjugate vaccine prevent asthma?
It has been shown that pneumococcal conjugate vaccine has decreased a number of exacerbations.
No, I think a pneumococcal conjugate vaccine will not reduce the recurrence of asthma in a child. I don't think so. What are the PCVs that is available now?
PCV10 given in the National Immunization Program, in PCV13 and PCV20 is available.
Is going to be available now.
Recently coming up.
And also PCV15 is also in the pipeline. So among the PCVs available now, we have heard the old PCV10, PCV13 is there, and the new PCV10 is there. And what should be the preferable PCV now? Which will you prefer?
PCV20 if available.
No, it's not available. It is in the pipeline.
PCV13.
In US it is there. You
PCV13.
PCV13 and not PCV10, but government is giving only pneumosil, which is PCV10. You prefer to have PCV13?
Yes.
Maybe PCV13 may be preferred. What I say is that in the private sector, IAP recommends PCV13. I am working in a private hospital. In a private sector, we advise them to give PCV13 because they can afford to have PCV13. But in the government sector, when you work in the government sector, PCV10 is also equally good. But it is better to give a vaccine which contains more strains. Then PCV20 comes, you may prefer for PCV20. Then what about this influenza vaccine? Now influenza vaccine is easily available. All children are giving influenza vaccine. Can it prevent asthma?
It has shown to have protective role in asthma.
Yes.
Annual influenza vaccination has shown to have protective effect in
asthma, right? Because see, when compared to pneumococcal vaccine, influenza vaccine may have some protection because influenza virus A and B may be a trigger factor for asthma, and also you can reduce the incidence of recurrent respiratory infection, and also the incidence of asthma may be less. In asthma triggered by influenza virus can be reduced by giving a yearly vaccine, yearly influenza vaccine, right? Okay, right?
No family history, no history of bronchial asthma, atopy, eczema, dust or food allergy or tuberculosis in family.
So
no
it is very
history of
important that you
allergic-
must ask a history of atopy, history of asthma in the father, mother, and
Yes.
sibling. The history of asthma in the mother or father is more important.
Father, sir. Paternal,
Or
paternal
maternal.
gene is more linked.
Hey, it is maternal gene. Maternal gene is very important. If the mother is having asthma, the chance of developing asthma in a child is very high. Maternal asthma is more important than paternal asthma. But if both parents are having asthma, there's a 50% of chance of developing allergic asthma in a child. So you must ask a history of asthma, history of other atopic disease like eczema, and also allergic rhinitis, and also food allergy in these children. Okay. And
Yes, we should
TB,
know.
I think why you ask about TB?
Say differential diagnosis, sir. It's since they are having symptoms, maybe.
TB is probably not a differential diagnosis of asthma in a child. Probably, but it is very important. In any respiratory problem, you must ask to rule out tuberculosis. Any child, but in this child can be TB.
No.
As per the history.
No, sir.
When you suspect TB in a child.
No response to.
No, symptom. Again, we are talking about
symptomatically, cough should be persisting for a period of 2 weeks without.
That is
relief.
persistent cough, more than 2 weeks. Then
loss of weight, loss of appetite, and significant.
And most important symptom.
And then evening rise of temperature.
So you mean, sir, evening rise of temperature is seen in childhood TB. See, childhood TB, they are present with an intermittent fever. So it should be not evening rise of temperature. Evening rise of temperature is seen only in adult type of TB and not in children. So a child presented with persistent fever for more than 2 weeks, persistent cough for more than 2 weeks, failure to thrive or loss of weight, you suspect TB in a child. But in this child, the symptoms are mainly recurrent episodes of wheezing. Okay.
Socioeconomic history, child belongs to lower middle class family according to modified Kuppuswamy scale. Father is a manual laborer educated up to +2 and mother is a homemaker who is a graduate, and their monthly income is 10,000 to 15,000. Now, environmental history, child lives in a concrete house with 2 bedrooms. Flooring is done with a tile, well water with adequate sanitation facility. Now, exposure to indoor pollutants like pet dog present with frequent handling by the child, firewood burning present, passive smoking present, cockroaches are present at home, but no perfume or talcum powder usage. Now,
very good. Okay, right. Outdoor pollutants, right?
Outdoor pollutant exposure history, school is located close to main road with a exposure. No factory or source of pollution near home or school.
See, in a respiratory problem like this, it is very, very important that you must take a detailed environmental history in the form of indoor pollution and outdoor pollutions. Among the indoor pollution, what I have seen is that in my study also, we have seen that the commonest trigger factor is passive smoking. In all children who is present with a recurrent respiratory infection, recurrent pneumonia, recurrent ISOM, recurrent asthma, you must ask the history of passive smoking. That is very, very important. And I have seen that the most troublesome person is the grandfather. The grandfathers will smoke rather than the parents. And so passive smoking definitely must be, especially if a child is not responding to asthma, respond to your inhaled medications, you must look for passive smoking. So to sum up, what is your impression now? You can sum up the case now.
Sir, from the history, it appears to be a case of acute severe exacerbation of intermittent asthma with intermittent moderate to severe allergic rhinitis.
Why? What are the points in favor of, you said is a mild persistent or intermittent?
My intermittent, sir. Symptom pattern, child is having episodes.
Why this, first of all, you say why this asthma in this child?
Child is having more than 4 episodes with a good response to bronchodilator.
More than 4 episodes of what?
Of cough, breathlessness, and wheezing. And that is
what are the causes of wheezing? Even Dr. Cyril was telling me, I usually say ABC of wheezing. I think we can just remember the ABC of wheezing, which I usually give. What is the ABC of wheezing? What are the conditions?
A stands for asthma. B for bronchiolitis.
No, A stands, there are a lot of A's are there. Asthma, aspiration syndromes, asthma phenotypes. B? B? What are the conditions starting with?
Bronchiolitis and bronchiectasis. B.
Yes, right.
C stands for cardiac causes,
And cystic fibrosis.
cystic fibrosis.
D.
D for drugs like aspirin and other NSAIDs.
And also propranolol, beta blockers. Right.
Beta. Then
E?
E stands for endobronchial. T.
Endobronchial tuberculosis. They can present
Tuberculosis.
with rarely. Tuberculosis, the bronchus can present with wheezing because it can also produce bronchial obstruction. Then
F
Any other
stands
E?
for
E,
foreign
any other
body.
E?
Sir,
E, any other E? Very common.
E.
So lymph nodes pressing on the bronchus. Extrinsic compression. Extrinsic compression of the bronchus by a lymph node. For example, a child with a lymphoma, again to TB, they can extrinsic compression. Yes, then F.
F stands for foreign body.
That is very common. A child presenting with an acute onset of
Acute
cough
onset.
and breathlessness, choking episode. It may be a foreign body. G.
G for GERD, gastroesophageal reflux.
H.
H for H-type tracheoesophageal
Oh.
fistula.
Yes. H for H-type tracheoesophageal fistula. I. Any condition that start with I that can produce wheezing in a child, especially in children less than 5 years. All these conditions are more commonly seen in children less than 5 years. I is interstitial lung disease. Interstitial lung disease. Then interstitial lung disease and immunodeficiency. A child with an immunodeficiency can present with recurrent respiratory infection and wheezing. And when you suspect an immunodeficiency in a child,
Recurrent otitis media.
Right. Especially in a child with a primary ciliary dyskinesia, they can present with the recurrent ASOM. Then
More than recurrent pneumonia.
yeah, recurrent infection. Then I usually say somebody has written SPUR, SPUR. The short form is SPUR. S stands for serious infections like pneumonia, severe infections. P stands for persistent infection. U stands for unusual infections like Pseudomonas infection or a child with pneumocystis carinii pneumonia. R means recurrent infections. Bar is then you must look for immunodeficiency. Among this list, you can ask one more condition, V, vocal cord dysfunction syndrome. Vocal cord dysfunction syndrome can also present with wheezing. So these are the common conditions, ABC of wheezing. You must just remember this condition, especially in children less than 5 years. You must exclude all these conditions to arrive at a diagnosis. As Dr. Darley was again highlighting, one should remember asthma can present without wheezing. And all that wheezes are not asthma because there are other conditions that present with wheezing. And asthma can present without wheezing also. So this child has presented with the recurrent episodes of wheezing. Then what are the points in favor?
Symptomatic worsening during early morning hours and response to bronchodilators.
Yes.
And child's frequency was only 2 to 3 episodes one episode in 2 to 3 months. And child was having only 1 exacerbations in 1 year. And
what is the present problem?
The present problem is an acute severe exacerbation.
Acute severe. What do you think the severity of acute flare? Now you call it an acute flare, not acute exacerbation. You don't say this acute flare. What is severity? What is
severe exacerbation, sir, because child had a PSI score of 7, sir.
You said this was more than 6. So it is severe.
Yes.
So then in a child like this, you must also look for associated comorbidities. So what are the comorbidities in these children, this child?
Allergic rhinitis.
The comorbidities is allergic rhinitis. Then one more thing is that what is the trigger factor?
And this child, it appears to be upper respiratory tract infection, passive smoking.
Passive smoking is there.
Exposure to indoor allergens like cockroaches firewood burning is there at home.
Oh, so multiple factors are there. Right, proceed. Proceed now. Examination.
No, child appears, child was alert, appeared tachypneic, no pallor, icterus, clubbing, cyanosis or lymphadenopathy, heart rate was 130, regular rhythm and normal volume, no radiofemoral delay, BP was 96/60 in right arm supine position, respiratory rate was 34, oxygen at the time of examination, SpO2 was 95% in room air, and temperature was 99°F. Head to foot examination was within normal limit. Anthropometry showed a weight of 17 kg with an expected of 19 kg and at 25th centile. Height was 120 centimeter with an expected of 117 centimeter between 50 and 75th. BMI was 11.8 between 3rd and 5th centile. And respiratory system, upper respiratory tract.
See, what are the things you must look in the general examination this child? General examination.
Any features of allergic rhinitis?
What are the features you must look for?
Allergic salute, allergic sheen.
Just salute. The child will always rub the nose like this. Then
Allergic sheen around the eyes.
allergic shyness. Allergic shyness. There is hyperpigmentation around the eyelids. Allergic shyness can be there. Then what is Darius line?
Sir?
Darius line. Have you heard of Darius line?
No, transverse.
Yes. There will be a transverse crease just above the
nose.
no. That is called Darius line. What is Denny Morgan sign?
Denny Morgan.
There will be an ridge will be there. Denny Morgan sign may be seen in atopic dermatitis also. Then you must look for hypertrophy turbulence. You must look for. Then you must look for any symptoms of hypertrophy. So these are the things. Then most important thing is you must look for clubbing.
Yeah.
What is the importance of clubbing?
Bronchiectasis.
Yes.
Cystic fibrosis.
Not only bronchiectasis, it's an evidence of a chronic lung disease. Any child with who is presented with a recurrent episodes of cough and wheezing, you must have a chronic lung disease. What are the main clinical features of a chronic lung disease? Clinically.
Sir?
What are the features of a chronic lung disease when you suspect a chronic lung disease?
Chronicity of symptoms will be
No,
without
examination.
examination. Clubbing.
Clubbing. Clubbing is the most probably is the child will have a chronic lung disease. Then cyanosis.
Anthropometry wise child will be malnourished.
Most important is anthropometry. Dose faltering. If there's a short stature is there and malnutrition is there, then the child is having bilateral clubbing, cyanosis, desaturation, then you must look for a chronic lung disease. So you must look for a evidence of chronic lung disease. Is there evidence of a chronic lung disease in this child?
No, sir, no.
Okay, right. Continue.
Now, nasal discharge was present, no ear discharge. Chest examination, in inspection, trachea appears central, shape of chest normal, chest wall was symmetric with equal movements on both sides. Palpation, position of trachea was confirmed with the palpation. Chest expansion was 3 centimeter, no palpable pulsation. Vocal parameters had normally in all lung areas. Percussion showed normal resonant note in all areas. Normal vesicular breath sound. In auscultation, there was normal vesicular breath sound with an expiratory wheeze, and vocal resonance was heard normally and equally on both sides. Other systems, cardiovascular system, other systems was within normal limit.
So what are the positive findings in examination?
Tachypnea is there. And saturation is 95% in room air.
That is normal, no? Then?
And end expiratory wheeze was there.
End expiratory wheeze was there.
Yes.
Liver spleen?
No, sir. No push down liver or spleen.
Any evidence of a chronic lung disease? Is there evidence of a chronic lung disease?
No finding, no clubbing, no cyanosis. Child was.
So what is your diagnosis now after examination?
Now the child is having only features of moderate exacerbation.
Of acute asthma. Moderate exacerbation of intermittent asthma. With allergic rhinitis. Allergic rhinitis. With acute flare. That's a diagnosis. Now, how will you confirm the diagnosis now?
Mainly by symptomatic improvement to bronchodilators, and flow spirometry can be done.
What do you look in the spirometry?
In fractional, if fractional expression volumetric first FEV1 and FEV1 by FVC ratio is used for diagnosis.
FEV1 by FVC ratio
more than
less than
80%.
more than 80%.
Normally
It's
more
normal.
than 80%.
What a PEFR?
A peak expiratory flow rate.
What is the importance of PEFR?
The annual variation of PEFR more than 13% is could be.
It's a improvement in PEFR by 12% after giving a short-acting beta-2 agonist. It may be taken as evidence of asthma, but PEFR is not important for diagnosis. PEFR is mainly for monitoring children with asthma.
Monitoring.
For children diagnosis of asthma, you must look for a spirometry and you must look for FEV1 by FVC ratio in all children. Especially in the GINA guidelines say that if possible, you must do a spirometry in all these children. That should be done. But in children less than 6 years, which investigation do you do? Small children.
Rapid volume transthoracic compression.
What is it called? What is it called? Right. What is it called?
Sorry, forgot the name, sir. Rapid volume transthoracic compression.
What is the name for that? It is an infantile oscillometry. You can do for an oscillometry can be done. Oscillometry is the pulmonary function test in children less than 6 years. It is done in some of the centers like Gangaram Hospital. One Dr. Neeraj Gupta is there. He is conducting a lot of study on oscillometry for the diagnosis of asthma in a child. Then what other investigation will be done in this child?
Routine blood investigations
Will
and chest.
it help? Will it help?
No, not in diagnosis.
Not in the diagnosis. Okay, then. In the investigation, see, what about IgE estimation? Will you do an IgE estimation in this child?
In case of it can be elevated in case of a topic.
Will you do routine IgE?
And also for treatment, if
total IgE is not done. It is not very important in a child with asthma. Total IgE is not. But in those children whom you are planning for an immunotherapy, you can do an immunocap, and also you can look for specific IgG, and skin prick tests are done only in those children who needs an immunotherapy. But immunotherapy is very rarely indicated in children with asthma. In children, according to GINA guidelines, in children with step 3 or step 4, and in children who are allergic to 1 or 2 allergens, which is found out by a skin prick test, you can go for immunotherapy. So immunotherapy is very much limited in a child. Childhood asthma, it is not limited. Where child is not responding to pharmacological treatment, and by the skin prick test, if the child is having allergy to 1 or 2 allergens, then you can try for immunotherapy can be tried. So how will you manage this child? X-ray is it important in this child? Just show the X-ray in this child. X-ray.
This is the chest X-ray of this child.
Show the previous CBC. What is that in the CBC?
In the CBC, the total count was slightly elevated.
Slightly or more is elevated?
Yeah, it's elevated.
No, what is the
importance? In the beginning, it was elevated.
Why? Then with the guy is having a neutrophilia.
Acute inflammation is there.
Acute inflammation or infection?
The flare was precipitated by an acute infection.
Acute, you mean an acute bacterial infection. Bacterial infection rarely precipitate an acute episode of asthma. See, maybe due to steroid therapy. See, it is seen that those children who receive steroid, what are the hematological problems with steroid therapy in CBC? What are the changes you see after giving hydrocortisone, prednisone? There can be leukocytosis, neutrophilia, leukocytosis, neutrophilia, and eosinopenia. Understood? Leukocytosis, neutrophilia,
Neutrophilia.
eosinopenia are manifestations of steroid therapy. And I think, personally think, I think it is
Steroid.
not due to an infection. It is due to steroid therapy in the early phase can produce all these changes. X-ray, just show the X-ray. Miss, what about X-ray?
About intercostal about 6 intercostal space are being shown. So there is hyperinflation.
Hyperinflation is there. Then
Then
you
slight
said there's an
straightening of-
acute infection in this child. Is there any evidence of pneumonia in this child?
no
No.
evidence of any infiltrates. Only increased bronchovascular marking is.
So children with asthma, X-ray is not confirmatory. X-ray may shows an emphysema just can be there with prominent bronchovascular marking. But X-ray may be taken to look for other complications. So if the child is very desaturating, you can look for complications like pneumothorax. And also, rarely in the first episode of VC, you may take an X-ray to love tuberculosis and other conditions. Otherwise, X-ray is not very important. So how will you manage this acute episode in this child? Acute episode, how will you manage?
The mainstay of treatment is a bronchodilator, short-acting beta agonist. Since the child is a 6-year-old, we can give MDI. Initially given 20 minutes apart 3 times to be spaced out according to response. Along with it,
so in children with
steroid.
acute asthma, mild to moderate exacerbation, you can treat with MDI. What is the dose of MDI to be given? You said.
According to 200, we usually give according to the 200, according to the weight of the child.
Oh, so you meant see MDI, you adjust according to the weight of the child or age of the child?
Age of the child.
Oh.
More than 6 years, we usually give 6 to 10 puffs can be given.
Yeah, less than 6 years, 6 puff. More than 6 years, you can give 6 to 12 puffs.
6 to 10 puffs.
So the drug of choice should be salbutamol. Then 3 doses. Then at 20 minutes
then
interval.
Space out. Then steroids, usually prednisolone can be given 1 to 2 mg per kg.
Which steroid is given? So the second drug is steroid or something else?
Systemic steroids.
Or something else? Or you can give
as add-on therapy with
hypertropium. Okay.
Ipratropium can be given. As in the first hour only, we can give ipratropium also.
Then which steroid is given?
Sir?
Which steroid is given?
Prednisolone is preferred, 1 to 2 mg per.
Oral prednisolone.
Kg
See,
per
oral
day.
prednisolone is equally effective. Either you can give hydrocortisone, methylprednisolone, or dexamethasone. But as you correctly said, you can treat with oral prednisolone. Oral prednisolone is equally effective, and the child is tolerating oral prednisolone, you can give this. The child is having no vomiting, you or give out the oral prednisolone. If the child is not responding,
if the inhaled corticosteroid has also to be added.
there's see there are a lot of controversy regarding inhaled corticosteroid. It is a controversial issue. See, the thing is that the drug of choice should be a systemic steroid. So along with systemic steroid, you may give a inhaled corticosteroid. Otherwise, it is not going to be effective. Inhaled corticosteroids alone is not effective for management of acute severe asthma.
Then if there is no response, we can try other drugs like magnesium sulfate, aminophylline, etc.
You can try.
Yes.
Magnesium sulfate can be given intravenously.
Yes.
In the acute phase, the first 1 hour, you can have nebulous magnesium sulfate. And aminophylline, what is the role of aminophylline? IV aminophylline treatment of acute asthma?
According to the role is the role is said to be controversial because of the narrow therapeutic index and
see, in a child who has already received salbutamol, ipratropium, and hydrocortisone, no more bronchodilation is produced by aminophylline, and aminophylline has got a lot of drug interactions are there, and so it is not preferred. It may be the last resort. In a child with a very acute severe asthma in a PAC setup, if the child is not responding to other drugs, you may try for IV aminophylline. Then if not responding, you go for ventilation, by non-invasive ventilation. But all these things are not required. Most of our children, they will respond to salbutamol and then hypertropium, IV hydrocortisone, and IV magnesium sulfate. Most of our children will respond. What is the long-term management in this child? Long-term management?
Child has to be started on an inhaled corticosteroid since it is a case of the present episode was of severe exacerbation. We have to give an inhaled corticosteroid, preferably for a period of till the child becomes symptom-free for a period of 3 months.
That is no. You can start with the inhaled corticosteroid alone or a combination. This child is
since the child is 6 years, an ICS formoterol is preferred according to the latest.
Why it is preferred? Why it is preferred?
It has been shown that the one thing is it can be used both as a controller as well as a reliever.
Oh, right. That is very important because the formoterol can be used as a reliever as well as a controller. This is called a MART therapy. Maintenance and reliever therapy can be done. See, the preferred drug, the long-acting beta-2 agonist in a child above 6 years should be formoterol rather than salmeterol. Formoterol, which acts as a reliever as well as a controller. But in children, it is very important that in children less than 5 years, you should not use a long-acting beta-2 agonist. Should not be given in children less than 5 years. In children less than 5 years, the drug of choice should be inhaled corticosteroid, either budesonide or beclomethasone. It should be given in increasing doses. It should be given. And also you must go for a step-up management. We are not going to the details of the step-up management. So this child should be having a preventer. And how long will you give this preventer? You said 3 months. After 3 months.
Controller has to be given and for a period of at least 8 to 12 weeks. And if the patient remains symptom-free, it can be stepped down. The dose can be stepped.
You can give a full dose of inhaled corticosteroids or a combination of inhaled corticosteroid with long-acting beta-2 agonist for a period of 8 to 12 months. If the child has responded, you can start stepping down, and also you can continue with a low dose of inhaled corticosteroid. What are other drugs that is being tried for treatment of asthma?
Agents like
children above 6 years.
Omalizumab, anti-IgE.
Before that, what is the role of long-acting beta-2, long-acting anticholinergic drugs?
Long-acting antimuscarinic agents has been added recently in the step 5 of controlling of asthma. Step 5.
In step 5, you can try LAMA. Tiotropium bromide can be given in children above 6 years.
Antagonist has also been.
What is the role of leukotriene receptor antagonist?
Especially in cases of allergic rhinitis with asthma, leukotriene can be.
There is some role for leukotriene receptor antagonist in those children who are presenting with allergic rhinitis with asthma. But again, for allergic rhinitis, the drug of choice should be inhaled nasal spray. Nasal spray. The child is having associated asthma, you can go for leukotriene receptor antagonist. But leukotriene receptor antagonists are the most misused drug now. There is no much indication for giving leukotriene receptor antagonist because the anti-inflammatory effect of leukotriene antagonist is definitely inferior to inhaled corticosteroid. So drug of choice should be inhaled corticosteroid, then act for a increasing in dose of inhaled corticosteroid, then go for a long-acting beta-2 agonist, then LAMA, then the step 5, we can have a trial with oral steroids, or you can go for some of the biologicals. What are the biologicals that is given for management of asthma?
Anti-IgE agents like omalizumab.
Yes, then.
Anti-IL in the looking 5 agents like reslizumab and mepolizumab.
Mepolizumab, then?
Then anti-thymic stromal hematopoietin agent like dupilumab.
Dupilumab can be given. I think I will just quickly go to some of the newer drugs in asthma. Can you stop sharing this slide?
Yes, sir.
Slideshow. Slideshow. I will just quickly show you some of the slides.
Sir,
Yeah, right. Right. Can you see the slides?
no, sir.
Not seen.
No, sir.
Not seen. I think
No.
so.
Not seen. Not seen.
Not seen. Yes.
It's not getting shared right now, sir. Manu Ranjit, can you make Sar the host? Then only he will be able to share it.
Okay, even co-host can, sir. I can make him the host.
Okay,
Let
you
me
convert to host.
Okay.
Sorry, now we can try. Suman sir, can you once again try?
So please try it now. I made you the host.
Coming, sir.
No.
Sir, please try again.
Cano.
Done it again.
Not it, sir. Not it, sir.
Yes, yes.
Okay,
Now it is okay.
Okay. These are some of my studies. This is the latest study on asthma. The largest study on asthma is by the ISAC study group, which was done way back in 1995. Now the new study is called GAN study for Global Asthma Initiative. And this is the results of the GAN study. GAN study has shown that there's a decrease in the incidence of asthma in low-income countries in 13 to 14 years, and increased incidence in lower middle-income countries, and was static in upper middle-income countries. And this study was conducted in 6 centers in India. These are 9 centers in India. These are the centers where this GAN study was conducted, and this study is published in European Journal of Respiratory Disease. Then this is very important. Even though this is GINA 2019, the most important thing is that the fundamental change in the asthma management is treatment of asthma with short-acting bronchodilators alone is no longer recommended in children, even adults and not only adults and in children also. So always you must combine a short-acting beta-2 agonist with an inhaled corticosteroid, because if it's using short-acting beta-2 agonist alone, it can increase the recurrence of relapse of asthma. There will be high incidence of recurrence of asthma, and these children develop severe episodes of asthma in a child. Then I think you can read the guidelines. These are the newer GINA guidelines. I am not going to detail GINA guidelines. Then newer drugs, I just named the new drugs. As she said, omalizumab is a monoclonal antibody against IgE. Then mepolizumab is an IL-5 monoclonal antibody. Rasulimab is an anti-IL-5 antagonist. Dupilumab is, again, it is an IL-4 antagonist, and is being tried in the treatment of atopic dermatitis also. Then benralizumab, oligonucleotides can be tried. Then regarding vitamin D supplementation, routine vitamin D supplementation in antenatal period will modify the asthma risk in infancy. It is not very sure. Those mothers who are vitamin D deficiency, having deficiency, you can supplement vitamin D. It can prevent recurrence of asthma in the baby. And also vitamin D and childhood asthma, there are controversial literature is there. Some people say that it can protect the child against vitamin D, but there is no recommendation on routine vitamin D supplementation for prevention of asthma in a child. And before I conclude, you must know the prevention of asthma, exclusive breastfeeding, vaginal delivery. As I said before, judicious use of antibiotic in first 1 year of life is important. If you are giving more antibiotic, and also you must avoid use of paracetamol in early infancy. Injudicious use of paracetamol and antibiotic in early infancy can lead to all allergic disorders in children. Discourage early introduction of at-risk food like milk, egg, peanut, seafood, meat before 1 year of age. Avoid exposure to animal dander. It's also a controversial field. It is said that if a child is exposed to, if a baby is exposed to pet animals very early in infancy, first 1 year of life, they may be protected from asthma. Avoid exposure to dust mite and immunotherapy. The only indication for immunotherapy is that those children with asthma who are not responding to pharmacotherapy and on skin prick test or immunocap, they are sensitive to 1 or 2 allergens, you can try for immunotherapy. So I think we will stop now. Thank you very much for giving this opportunity. And I think we will take a few questions if time is there. Suresh?
So, sir, the session is now open. Any of you want to clear any doubts, you can ask any questions. Purushottam sir, for your comments.
Purushottam sir. Okay.
Thank you, sir. That was a great learning session as usual, sir. Yes, and Ansha, they presented very well. And mentor, Dr. Cyril, congratulations. Sir, regarding the last few points about the paracetamol, antenatal period, pregnancy also paracetamol is one. During pregnancy, that's also having an increased chance of
No. The studies are on paracetamol for babies. And even the ISAC study also, we have conducted a survey on the prevalence of paracetamol allergy, paracetamol intake and asthma. And it is seen that there is a high incidence of asthma in those children who are taken, babies who are taken paracetamol. I think there are no studies on maternal intake of paracetamol and asthma.
Very good. Also.
So I think, what do you say that we must use all this drug judiciously in children? We routine supplementation of paracetamol after vaccination. All these things are not required. I think you should not routinely recommend paracetamol syrup for vaccination. But if a child after vaccination is having fever and body pain, local tender pain, then you give paracetamol. But routinely, I think you should not recommend these things. And also, you must be very judicious about the use of antimicrobials in the newborn period.
Regarding the vitamin D part, because the American Heart Association and now IAP also recommending the vitamin D routinely in all term babies. That is contradicting our own previous statement of nothing for the up to 6 months or exclusive breastfeeding. Now we have gone back and liberally we are all giving vitamin D. Rather than that, if the calcium supplementation vitamin D is given the second half of pregnancy, there are a lot more benefits. And even that can be given to the mother during lactating mother. There were studies, 1.2 lakhs every month. That is, so rather than giving this vitamin D to the less than 6 months term babies otherwise, can't we go to the supplementation of the pregnancy last trimester and the lactating mother?
Okay, I think as Purushottam said, I think the routine supplementation of vitamin D for all newborns, even enough recommendation is there. I think is it required or not is a big question.
Sir, this kind of supplementation, we are having children with a vitamin deficiency at 1 year of age.
But the thing
That
is,
Suresh, but there is no proven study that is required for every baby.
The thing is that the estimation of vitamin D is also not very correct. See, I have seen the reports of children coming with leg pain, bone pain, non-specific complaints for which vitamin D estimation is routinely done. And I have seen most of the children vitamin D level is less than 20 micrograms, 20 insufficient, but they are not having no clinical features of vitamin D deficiency. And even children with the vitamin D level of 10 microgram. Yesterday, I had a talk by Dr. R.V. Jayakumar in our clinical meeting at Caritas. He was also saying that typical rickets will be seen in children if the level is less than 10 micrograms. But it is also not seen. I think we are this results of this vitamin D estimation is not very, very correct. I think we should not depends on our labs for level of vitamin D. Most of the children we see, the level is less than 20.
I think, sir, the results are not standardized or validated from many labs.
Yeah.
Many labs.
Right.
They have their own standards and their own values and units for the particular values. So that is not accepted. Sir, there are 2 questions in the chat box. Can asthma occur without cough? One.
Yeah.
And can you explain
that
the
is
role
that
of
is a very
spirometry?
important. What is the first question? Can asthma occur without cough?
Occur without cough.
Second. Then I will answer
That is
that.
the role of spirometry.
The asthma cannot occur without cough. Cough is the most important symptom of cough. Even in children under 5 years also, cough is more important. Cough is the most important symptom. Because when you compare asthma with pneumonia, cough is not a predominant symptom because it's an alveolar disease. But asthma is a disease which mainly affects the bronchus and bronchioles. And most of the cough susceptibles are present in the bronchus, bifurcation of the bronchus. So cough should be there for diagnosis of asthma. And the main symptom of asthma is persistent cough, recurrent cough, which responds to a bronchodilator. I have not seen asthma without cough. But it's a very clinical diagnosis. But those children without cough may have a bronchial hypersensitivity may be there. But normal children will have also bronchial hypersensitivity. But other than asthma will not occur without cough. Without cough, one should not diagnose asthma without cough. See, the last 1 month back, I heard a talk from ICH Chennai. They were talking about under 5 years. Again, he was talking, asthma will present with cough, especially in children less than 5 years also. Persistent cough should be there. Without cough, you cannot diagnose asthma. Second question.
The second question is role of spirometry.
This spirometry, our GINA guidelines say that if facilities are there, all children you must do a spirometry. Facilities are there, you must do a spirometry before starting a treatment for asthma. Before starting a preventive therapy, you must start spirometry. And oscillometry is coming up in a big way for diagnosis of asthma in children less than 5 years. But in most of the facilities are not available, and it's very difficult to do spirometry. I am also not doing spirometry for our children, but it's very difficult, and very good technician should be there. So difficult, but the GINA guidelines say that it is better to have a spirometry before starting treatment of asthma.
So why we are telling that cesarean is a risk factor for development of asthma compared to vaginal? Why cesarean is taken as a risk factor for asthma compared to vaginal delivery?
See, it is seen that when a child is born vaginally, I think they swallow the vaginal secretions, which contain most of the bacteria, which can protect our children from allergic disorders. This is just like a probiotic. Probiotics are being tried for management of asthma. So there is some.
So recent nutritional guidelines especially from the Canadian guidelines, they have introduced meat and other protein foods early in the infancy itself. And we are, for our asthma purpose, we are telling that these animal foods and other extra protein should be introduced to the diet of the baby only after 1 year of age. So these two seems to be some contradictory statements.
It is there. It is there. I have read that. Read that. But it is seen that early introduction of allergens may prevent asthma later. Even that is true with pet animals. Early exposure in early infancy, first before 1 year, the child is exposed to rat, cat, etc. They are protected from asthma.
Hygiene hypothesis, sir.
Hygiene hypothesis. Again, it is seen that those children who are born and brought up in farmhouses, who are staying in the farmhouse, along with these pet animals and cows and dogs and all these animals, they are protected from asthma. This is also there. Very early exposure, the child may get protected.
Anshad, can you project that PSI scoring slide?
Anshad, are you there?
Yes, sir.
PSI scoring.
Can you share that slide? PSI score
Yes, sir.
slide.
Yes.
My
Yes, sir.
doubts.
While
I will
you
post, I
are
will
doing
post.
that, let me ask Suman sir another question that came up in the chat box. Sir, what is brittle asthma?
Previous PSI scoring slide. Okay.
Okay.
In that, okay, end expiratory visa, I was confused about the novice situation. That is 0 scoring. Okay, that's right.
No wheezing is 3. Inspiration plus, expiration plus, audible wheeze, silent chest, silent chest.
Silent chest is 3, sir. The
silent chest
first
is
thing,
3.
0,
Yeah,
0
right.
scoring. The last novising is 0. That's right. I was confused about that.
Brittle asthma is not very commonly seen in children. It is mainly commonly seen in adults. These children will present with-
Cough variant asthma. We are getting cough variant asthma.
But the thing is that most of the guidelines say that terminology is not very correct. Cough variant asthma is not a correct terminology. But if a child is presenting with a persistent cough and the child is responding to bronchodilators, it should be taken as asthma. In children with brittle asthma, there will be sudden deterioration of asthma. They will present with an acute episode. So with sudden deterioration.
Anshad, you can close the slide. I just wanted to see the slide. Dr. Shanavas is there, Jose is there, and Krishna Mohan. One important point. You should be seeing the PowerPoints before the this thing, because the X-ray and the ECG or some other documents are showing the identity of the patients. So it's in the YouTube. So be careful about the identity of the patient. The X-ray carry the name of the patient. So better edit that part before it's going into the YouTube recorded.
These slides are not usually shared to us, just the local coordinator that usually you see.
So the problem is that it's happening.
Very important. X-ray at least okay, no problem, but somehow pictures comes, it's very important.
So
Yes,
somebody
actually, when we are doing, we are masking the pictures to make it unidentifiable or identity getting not revealed.
It will be
For X-ray part, we will be looking into that again, sir. You will see that X-ray, the name and identity mark is not projected. We'll see to that.
We are saying it, sending it to YouTube. That's very important. It will be present there.
It will be there in the net for quite long. Yes, yes, sir. Agree with that.
You are the common factor. That's why I said Shanavas will be saying all this thing because it's going on rotating between the different districts.
We'll look on
So
that.
once I'm telling this thing, won't be carried in the next sessions. That's why I'm telling to Shanavas. Okay, thank you, sir.
Okay, Suresh, will you wind up? Once again,
Cyril,
thank
sir,
the
for your
organizers
concluding remarks.
for giving this opportunity. And also I congratulate Dr. Anshad for a very excellent presentation. Thank you.
No, sir, I should be thankful to you for accepting our invitation so quickly. The moment I called you, you accepted. I think I will be able to do that on Thursday itself. That was your word. I still remember that. And I asked you to wait for one more day and let me give the confirmation. So you was very, very helpful in taking that session today, sir. Thank you. Thank you so much, sir.
Okay.
Any comments, Cyril, sir? Otherwise, we'll conclude.
We'll conclude. As expected, it was very.
Okay. So it was a very interesting session. Lot of knowledge. So general awareness regarding asthma management. Okay, thank you very much, Sumaran sir. Thank you very much, Anshad and Suresh Varakadam sir and Charlie madam, and expand that to Cyril sir. So our regular Purushothaman sirs present and also